All right, everyone, thanks for being here. I hope everyone can hear me, and let's talk about prescription drugs. Here's the thing. Everybody recognizes now that this is a problem. We've been working on this, me, in Utah since about 2004, and there have been lots of different interventions related to opioid prescribing, talking to people about not sharing medications, and many of these interventions have happened on top of each other, which means that we can't very easily evaluate the impact of any of them. In this time, we've averaged about 300 fatalities of accidental and undetermined intent related to prescribable opioid medications a year, okay? Every time I talk about this, people say, ooh, what about suicides? As best as we can tell, it's staying pretty constant. In Utah, we see around about 50 to 55 identified suicides a year that occur with drugs. Firearms are much more common. Homicide is not really a big deal, but what we're talking about are deaths of accidental intent or undetermined, where the medical examiner says, I can't tell. There's not enough information here. But that said, I'm not really talking about fatalities today. But that's been the thing that's most in the public view. All right, so in Utah, we have a prescription monitoring program, as many states do now. Ours was created in 1995 by legislative mandate, which gives us the distinction of being the oldest Schedule 2 through 5 prescription registry in the country. We have data going back to 1997. I would not suggest that anyone really use it until about 1999 or so. And it really is a registry of all of the filled Schedule 2 to 5 prescriptions in Utah and by Utah providers. So this data is submitted by pharmacies when prescriptions are filled. Okay, so everything I'll be talking about is filled prescriptions, not written prescriptions, because of course sometimes a doctor may write a prescription that a patient never fills, and we don't know about that. That's a limitation. Our controlled substance database has an online query system where providers can use their computers to log in and look up a patient. This has not been in existence all the way back to 1997. Technology didn't support that. But since the early 2000s, that has been available. That system has been underutilized, however, and in 2010, as part of all of these interventions happening about opioid prescribing, our legislature passed House Bill 28 that mandated providers must register with the online querying system in order to renew their controlled substance prescribing license. Now, importantly, it doesn't say they have to use the system. Okay? Regulating actual change in medical practice, a much harder thing than changing a rule that relates to licensing. So this is one of those things where the idea is, well, if we make them register for the system, then they'll see how easy it is and how cool it is, and hopefully they'll use it. But we didn't say that they had to use it. This passed through the legislature in March. Most of the licenses expire at the end of June. Most things on the medical, kind of the beginning of the year, is July 1. And the rule said that folks had to register by September 30th of that year. So here are our research questions. The first is that, did the implementation of House Bill 28 result in increased utilization of the online query system? And then, more importantly, did we actually see a change in potentially dangerous prescribing behaviors? Here's our plan. Well, we got from the people who run the controlled substance database, they maintain a web log of all of the activity on the system. Okay, they're very interested in if someone gets into the system who's not supposed to, and so they have this huge log file so they know who logged in when and what time and what they did, and every keystroke is there. So we use this to analyze the frequency of individual providers using the online query system over time, and I'd like to point out this is the first time anybody's actually tried to use these data. It's been really fun. There are a lot of great stories about how there's like codes that go along with the keystroke and nobody knows what they mean, or the person who knows won't tell. So here's the answer. System use has increased. Hooray! This is what we would like to see. In the green solid line, this is numbers of provider queries to the system. So this would be like, I am looking up Joseph Smith. I am looking up Emma Smith. So each one of these is a separate query, as best as we can tell. And so you see near that yellow arrow, there's a big uptick in online use of the system, and that was actually right concurrent with when this regulation was being passed. So this is kind of cool. I mean, it's not even taken effect yet, but people are talking about the system and that it exists, and people are using it more. That's great. We like to see this. We have a lot more queries happening now. Now, part of this is probably from other interventions. So we can't say this is all just from House Bill 28, but some of the concurrent timing is pretty compelling. So the second part of our plan is actually using the prescription data that are available in the Controlled Substance Database to generate patient and provider level prescribing histories. And I gotta tell you, I'm just gonna say this with one sentence, but the fact that we can do this is predicated on the last 7 years worth of work, okay? This system was never designed for anyone to be able to do this, and the fact that we have beaten it into a shape that we can do this is honestly extraordinary and has resulted in many papers and a dissertation and other things. We were able to use these patient and provider level histories to create indicator variables for what we're calling dangerous prescribing behaviors, actually using the prescription fill data. Because here's the thing, what do we want to move the needle on? Well, fatalities and other adverse events. Those are relatively rare events, thank goodness, but process indicators, such as a patient having 2 or more long-acting opioid prescriptions that are concurrent, that's a little bit upstream and maybe indicating patients that are then at risk for adverse events, okay? So we're trying to measure something that's a little bit upstream. And so we've created a whole series of these different flags. I'm just going to talk about 2 of them today. So one is that concurrent prescription of 2 or more long-acting opioids. And we have separate indicators for if it's the same provider or different providers, by the way. And the second is about concurrent prescription of a long-acting opioid with a benzodiazepine. So we're talking like OxyContin and Valium kind of a thing. Along with this, we're counting the numbers of providers and patients who are affected by these different prescribing behaviors and looking at time trends. So here we go. Oh good, this looks good for you guys. We have in the solid lines, we're looking at numbers of providers that when we run these flags against these systems, the numbers of providers that are doing these behaviors in a given month, okay? So you can see it's going down. For the broken lines, we're talking about the numbers of patients potentially put at risk by these behaviors, also going down. Now, you'll note that the biggest decreases, happened earlier on and are probably related to other interventions like our controlled substance prescribing guidelines, et cetera. But just note the continual downward trend. And I still think it's worthwhile in having further interventions because we want to keep pushing this lower and lower and lower. Again, the yellow star is when this House Bill 28 was passed. We saw a big decline around about that time, which is good. I mean, if you're using the system maybe for the first time and you can look up and say, oh, wow, this patient already has 16 OxyContin prescriptions, I'm not going to provide another one, then this is a behavior that we want to stop. In terms of what's going on there in May 2011, we're investigating that, but we're liking that things are really going down, down, down. So I've got a graduate student working with me on this, and we've been trying to work on different sorts of metrics that we could say, so we can see on average how many queries is a provider doing over time. And so I had her make this graph where 11 and 58 are the query codes that we figured out are the ones that we care about. And you see it's pretty consistent over time. And then something happened in the summer of 2010. And all of a sudden, our mean frequency of queries plummeted. And when I was trying to prep this talk, and I kept texting my grad student, hey, are those graphs ready? She finally emailed this to me and said, I didn't want to give it to you because I don't know what happened. So we looked at it a little bit more, and then I remembered about how licensees and logins expired June 30th. And then we checked another code, which is login failures. And you'll see that there's a nice reverse relationship there. And I bring this up not because this is a huge finding, but to remind everyone who's working with administrative data sets that you really need to interrogate your data and really asking questions about what has changed and what might be causing things instead of thinking that everyone just went on vacation in the summer. The thing that's really interesting to me is that it took several months for our typical provider query frequency to get back up to where it was following that time when everybody's logins expired. So, this is a problem, I would say, because it means in that time, providers that maybe would have looked people up were not. Rollouts and IT changes can make a big, big difference here. Well, so what did we see? We did see an increased use of our online system and concurrent reduction in dangerous prescribing following implementation of House Bill 28. And this, I claim, is evident even in the setting of multiple interventions because of compelling time trends. What are our next steps? Well, we're modeling the association between use of our online query system as an exposure, so categorizing providers based upon what proportion of their patients they look up. And we actually have the data to be able to do this. So use that as the exposure, and then as our outcomes, these dangerous prescribing behaviors, and then also actual adverse events, such as fatal overdoses in emergency departments among those patients. So that is in process. So back to our research questions, I'm saying the answer to both of these is yes. And the conclusion, well, regulatory change may have a meaningful impact on public health, and so it's worth it.